Okay. All right. Good morning, everyone. Once again, sorry. I'll be presenting on obstructive sleep apnea, evaluation, and management. So these are the objectives of the presentation. We're going to define OSA, talk a bit about the epidemiology of the disease, the history and examination findings that we look to elucidate, talk about some of the relevant investigations to this disease, as well as management options. Okay, so obstructive sleep apnea or OSA is a chronic disorder caused by repetitive collapse of the upper airway during sleep. It's a heterogeneous syndrome, and but the commonly defined accepted definition, as given by the American Academy of Sleep Medicine, is a greater than apnea hypopnea index of greater than 5 on polysomnogram or PSG sleep study. The AHI is calculated as the number of respiratory events, apneas, and hypopneas divided by the number of hours of sleep documented during a PSG study. So some further definitions. So an apneic event is a decrease in airflow by more than 90% for more than 10 seconds. With a respiratory effort is called an obstructive apnea. And without a respiratory effort is a central apnea. And this is important because it allows us to differentiate between the different causes of disease and it affects the treatments that we use. A hypopnea is a decrease in nasal pressure by more than 30% for at least 10 seconds, with either a drop in oxygen by 3% or an EEG arousal. A respiratory effort-related arousal is a sequence of breaths lasting greater than 10 seconds, characterized by increasing respiratory effort, but not quite meeting an apnea or hypopnea definition. And the respiratory disturbance index is the evaluation of the number of apneas, hypopneas, and respiratory effort-related arousals per hour. By way of these definitions, we can then characterize the severity of obstructive sleep apnea in a sleep study, with mild being 5 to 15, moderate being 15 to 30 apnea, hypopnea, AHIs, and severe OSA greater than 30. So in terms of the epidemiology, the disease is intimately associated with obesity, but obesity is not thought to be a causative factor, but an exacerbating factor. It's also strongly associated with cardiovascular and metabolic abnormalities. The initial figures for the epidemiology were first brought out by a study done by Young et al. In 1996 at the University of Wisconsin, showing a male to female preponderance of 2 to 3 males to 1 female. The population sampling was queried, but generally it's thought that there's a male preponderance in this disease, with a general prevalence of 24% in the population in men and 9% in women. So in terms of the history, obviously the gender and the age of the patient is important. You're more likely, as I said, to think that it may be OSA in men. The occupation is very important for these patients because you need to know if they are operating heavy machinery, driving, if they're pilots. These things, if you have a severe obstructive sleep apnea, will obviously impact your ability to perform your occupation properly. The impact of your symptoms and your quality of life, and how long the patient sleeps for, and their habits when they go to sleep, because that can give you an idea as to their sleep hygiene and allow you to differentiate between obstructive sleep apnea or another sleep-related disorder. This presentation is on OSA, but we must, as ENT surgeons, recognize that there are many other sleep-related disorders, such as insomnias, parasomnias, that need to be ruled out when we're evaluating these patients. So something we need to be aware of. We also need to know about our patients' regular daily activities, and again, how this disease is impacting on those. And it mustn't be underestimated in terms of the report from the bed partner. If the patient lives with someone, in terms of the frequency of snoring and arousals during sleep. Prior OSA investigation or evaluation is important. It can give us information as to the severity of the disease. And of course, what prior treatments the patient may have undergone before being evaluated by the ENT. Comorbidities, of course, are important. If the patient is a smoker, if they have any attempts at weight loss, that's also important, as it may indicate that the patient may benefit from bariatric surgery, for example. If the patient has a family history of OSA, which can clue into some element of craniofacial abnormalities or other genetic disorders that the patient may have that may predispose to OSA. What medications the patient may be on, and if the patient is an alcohol misuser or abuser, as it is known that alcohol can actually impact negatively on your sleep patterns or sleep hygiene. And we also must take into consideration the patient's goals, what they expect of the consultation with respect to this disease. And with that history, you are then able to subjectively determine the severity of the patient's obstructive sleep apnea. Um, Sorry. The measures of the severity are basically categorized based on these questionnaires. These are the commonly used questionnaires to determine the severity. This is the stop buying score, which uses the historical findings to basically categorize the likelihood of a moderate to severe OSA with a score greater than 5, indicating the patient is more likely to have a moderate to severe obstructive sleep apnea. With the Epworth Sleepiness Scale, also using a determinant of the patient's obstructive symptoms based on the activities that they perform during the day, with a score greater than 10, indicating that they may have a mild to moderate OSA, and a score greater than 16, a moderate to severe OSA that may require intervention. The examination of these patients must be detailed. It is is crucial in terms of determining what kind of interventions we're going to implement. Once again, the BMI of the patient is going to be important as to whether the patient may benefit from the input of our general surgery colleagues from bariatric surgery. The patient's blood pressure and cardiovascular and respiratory examination are important because they give us an idea as to whether the patient may have cardiovascular pathology as a result of their OSA or the presence of the metabolic syndrome, which will also need to be addressed. We need to determine if the patient has anterior rhinoscopy deformities in terms of nasal deformities, polyps, deficiencies in their nasal valve, and if there's evidence of factors that may increase nasal resistance in terms of septal deviation, once again, polyps, turbinate hypertrophy. As these factors tend to negatively impact the patient's sleep hygiene. Once again, we need to determine if the patient has any evidence of significant maxillary and mandibular abnormalities. It is known that there are specific syndromes that can actually cause patients to have significant obstructive symptoms, such as Down syndrome, Pierre-Robin syndrome, where you have retrognathia, as well as Crouzon syndrome, where you have craniofacial synostosis and relative maxillary hypoplasia. All of these things can actually increase the likelihood of obstructive symptoms in the patient. I highlight here a pictographic representation of the Friedman score, allowing which has implications in terms of the surgical procedure that you're going to do. It is important in terms of determining the degree of oropharyngeal obstruction the patient may have and the benefit of the procedure that you're going to implement. So the Friedman palate position 1 shows you the visualization of the entire uvula and tonsils. 2, the visualization of the uvula, but not the tonsils. 3, the visualization of the soft palate, but not the uvula. And position 4 allows for the visualization of the hard palate only. You also need to look at the oropharynx and the sagittal configuration of the soft palate. And this brings into relevance the concept of the alpha angle, which essentially refers to the angle that the soft palate and the tensor veli palatini muscles make with the posterior pharyngeal wall, with a acute angle being less favorable than an obtuse angle, as pictured here, because the acute angle more commonly indicates the patient will have a concentric collapse, whereby less invasive measures are less likely to be favorable. The tonsil size, soft length of the soft palate are also very important because these things can also indicate to you that the patient may be suffering from obstruction at that level. The neck circumference is also important. It gives you ideas to the degree of or the amount of soft tissue that the patient may have that may be leading to compression or obstruction of the oropharyngeal and hypopharyngeal airway, as well as the position of the hyoid bone. And of course, the endoscopic evaluation, which we will get into shortly, will give you further information about the level of the airway collapse. So the sleep study or polysomnogram is the standard method of obstructive sleep apnea diagnosis, but it is not only used to diagnose obstructive sleep apnea, it's used to characterize the severity of the obstructive sleep apnea and to allow you to differentiate between it and other sleep-related disorders. There are multiple, well, there are four basic types of sleep study devices. Type 1 is portable and the other three are, type 1 is not portable and uses the electroencephalogram, EMG, and multiple limb leads to monitor limb movements. Types 2 to 4 are portable devices and are recommended more so for patients with a higher probability of OSA. But regardless of the type of sleep study device you use, they generally create a report that looks somewhat like this, documenting the types of hypopneic or apneic episodes the patient may have, and the number of these, giving you the ability to determine the severity of the disease the patient may have. So another investigation that's commonly used is the drug-induced sleep endoscopy, and this is somewhat replaced the Muller's maneuver, which was used in the past. Just a note on the Muller's maneuver, it's not in this slide, but it is an endoscopic procedure where you assess the patient's degree of collapse at different levels, the nasopharynx, the oropharynx, and hypopharynx, by passing a flexible scope into the patient's nose and asking them to sniff at each level to determine the degree of collapse the patient may have. The drug-induced sleep endoscopy was developed because it was thought that this type of procedure may more mimic physiological sleep or natural sleep with the use of anesthetic agents to induce the degree of collapse that the patient may be experiencing at home. It is commonly indicated when planning multi-level, upper airway surgery, as well as to determine the anatomic candidacy for hypoglossal nerve stimulation, and for evaluation of airway failure after previous upper airway surgery, as well as investigation in patients on CPAP with unsatisfactory results. Now, obviously, if you have an allergy to the sedation agent commonly used, which is propofol, this procedure may be contraindicated in you. It may also be contraindicated in pregnant patients, as well as patients who have significant nasal obstruction, precluding endoscopy. So this is a video. I'm going to fast forward in the interest of time from the surgical video atlas. It essentially is showing you the positioning of a patient who is undergoing drug-induced sleep endoscopy. The patient is supine. The endoscopist is passing the endoscope into the nasopharynx, and it's going to be evaluating first the velum, looking to see the degree of collapse induced by the anesthetic agents, and then the tongue base and epiglottis. Also inspecting during jaw thrust, and also inspecting the hypopharynx. Now, this endoscopic evaluation tool gave way to the Vogt classification, essentially describing the degree of collapse at each of those sites, whether it is an anterior, posterior, lateral, or concentric collapse, and the degree of obstruction, whether no obstruction, partial obstruction, or complete obstruction. And this gives you an idea as to the level of surgery, the level at which surgery must be implemented. Of course, realizing the fact that oftentimes in OSA patients, the degree of obstruction is often multi-level, and multi-level surgery needs to be implemented. Um, so, sorry. So in terms of the evaluation of the patient, um, imaging is commonly not always or not is a controversy as to whether we definitely need imaging and the type of imaging that we need to use for these patients. It is more commonly used when performing surgical intervention on these patients, not necessarily diagnosis or categorization of degree of severity of the disease. Um, there are different imaging modalities used. What you see here is a lateral cephalometric examination, whereby the patient's craniofacial skeleton is assessed, and the degree of soft tissue collapse created by soft tissue structures on the X-ray. And this can give you an idea as to whether any bony surgical procedures may be more successful. There are some issues with the lateral cephalometric evaluation, though. It is usually done in the awake and upright position, which may not accurately categorize the symptoms the patient may experience while asleep. And the studies evaluating for cephalometric evaluation generally did not account for ethnic differences in craniofacial structure. And there are some issues in terms of the standardization of image acquisition, which may impact the ability of cephalometrics to predict response to surgical intervention. As such, there has been a move towards use of cone beam imaging, cone beam computed tomography. It is more commonly used where it's more widely available, in more commonly in developed countries. It has the benefit of allowing you to perform 3D volumetric assessment of the airway, which will be more beneficial in terms of your surgical planning. But there is limited high quality evidence supporting its use in routine airway assessment. And the cost is a lot more than that of a lateral cephalometric examination. There's some similar issues with image acquisition and correlation between upright images and position during sleep. So in terms of the treatment options that we can use for this disease, positive airway pressure is the gold standard therapy for obstructive sleep apnea syndromes, more specifically the continuous positive airway pressure. It maintains a positive pharyngeal, continuous positive airway pressure, maintains a positive transmural pressure so that the intraluminal pressure exceeds the surrounding pressure, essentially acting as a pneumatic stent to reduce the likelihood of airway collapse. All patients who have at least mild to moderate obstructive sleep apnea would benefit from an initial trial of CPAP because with correct use, it is actually very effective. The issue with the CPAP usage is, in fact, patient adherence or compliance because it's a very uncomfortable thing, a very uncomfortable device to use for a lot of patients, as well as the cost associated with this device, which can be in excess of $400 to $500, which can limit its availability to patients. There are different types of, I mentioned positive airway pressure, but
Why are you so
there are different types. Hello?
dramatic and so non-familiar?
Sorry, I can't hear you. Someone asking a question? Okay, I'll continue. So there are different types of positive airway pressure devices. There's continuous positive airway pressure, where there is a continuous transmural pressure being transmitted into the airway. There's also bimanual intermittent positive airway pressure, whereby there's a higher pressure placed into the airway during inspiration, where the collapse occurs versus expiration, which is thought to improve or was thought to be able to improve patient compliance, as well as auto-titrated positive airway pressure, where the pressure introduced into the airway is decreased or increased depending on one, the patient's results on a sleep study, as well as patient complaints. Now, in terms of the difference between these, a systematic review meta-analysis was conducted by Patel in 2012, which showed somewhat insignificant increase in the positive airway pressure usage per day in patients with auto-titrated positive airway pressure. There's still difficulties in terms of adherence with these patients. And as I said before, all patients with at least mild to moderate, and definitely severe obstructive sleep apnea should get some level of positive airway pressure therapy as their initial management once it's available. So this is a diagram essentially showing the simple setup for a continuous positive airway pressure device. So you're seeing it's actually strapped onto the patient's face with an air hose and a CPAP machine that's titrated according to the amount of pressure that you want to introduce in centimeters of water. And as you can gather, it's quite an uncomfortable device to use. But the efficacy of the devices has been quite extensively studied and supported. And here you see a study by Patel et al. Demonstrating a clinically significant reduction in disease severity, as evidenced by complete resolution or near resolution of their apnea-hypopnea index. And it's important to note that the positive air pressure machines can be titrated. In other words, the pressure that is introduced can be increased or decreased based on the patient's response and the apnea-hypopnea indices that the patient shows on a follow-up sleep study. And these devices now can even be programmed remotely to allow for titration. Some of the disadvantages in terms of positive air pressure devices, of course, include adherence, the ability of the patient to sterilize this device at home, and of course of the discomfort associated with the disorder, with the device, and of course the cost, which may limit its availability, especially in developing countries. Other therapies may include oral
It is an internet issue we're trying to sort out.
Morning, apologies for the brief disconnect. There's some issues with connectivity. Okay, so just gonna continue. So we got to oral appliances. So these are some devices that may be used in patients who meet criteria for positive airway pressure therapy, who may be either intolerant to or refuse positive airway pressure devices. And they're commonly referred to as mandibular advancement splints, appliances, or devices. They essentially protrude the mandible anteriorly, and this is thought to increase the pharyngeal airway space and reduce the collapsibility. They're contraindicated in edentulous patients as they wouldn't get a proper hold or seal. Patients with temporomandibular disorder may worsen the disorder, as well as patients with central sleep apnea, as it may not address the underlying cause of the sleep apnea. Patients who may need rapid correction of the obstructive sleep apnea due to very severe disease, and patients who may have neuromuscular disorders. Another example of a oral appliance is tongue retention device, sorry. And essentially it uses suction force that anteriorly displays the tongue during sleep. Side effects of this include tongue numbness, tongue pain, tooth or gum pain, and dry mouth. More likely to work in milder cases of obstructive sleep apnea. And of course, issues with compliance of these oral devices also abound. There's limited evidence on the efficacy of these devices, though, limited to case series. So hypoglossal nerve stimulation is another treatment modality that's used. It is a very topical treatment modality now. It involves the use of electrodes to cause forward displacement or advancement of the tongue. The commonly used device is that of the Integra 2 hypoglossal nerve stimulator. And this device gained FDA approval following the results of the STAR trial, which is a multi-institutional single group trial with 126 patients who were not adherent to CPAP and had a BMI of less than 32, with an AHI greater than 20 and less than 50, so moderate to severe disease, with less central or mixed apneic events. And it showed significant improvements in the apnea-hypopnea index with decrease of up to 68% in patients whose BMI was less than 32, without concentric circumferential collapse of the velum. Concentric circumferential collapse of the velum is thought to be a contraindication to this specific type of therapy, as the hypoglossal nerve stimulator did not address that level of obstruction. The indications, though, for this method of treatment have been challenged with further studies, especially with the widening of the BMI range. Now, it is even more used in patients whose BMI may be up to 35. And essentially, it's very commonly used now. The issue, of course, with this type of device is, one, the cost associated with its use, as well as its availability. And of course, it's a surgical procedure, so there are complications related to it. But the benefits in terms of its ability to be titrated. So this device can actually, the amount of hypoglossal nerve stimulation can be increased or decreased relative to the patient's apnea-hypopnea index. And it doesn't appear to awaken patients who are already asleep, which is, of course, a clear benefit. So this is a video essentially showing a hypoglossal nerve stimulator in a patient. And you're seeing the physician using the hypoglossal nerve stimulator to actually cause tongue protrusion when the patient is supine. And as you can, that will clearly have a benefit in some patients who may have oropharyngeal collapse due to either the tongue size or the tongue collapse. So there are traditional surgical mainstay management options for obstructive sleep apnea. Common etiologies of obstructive sleep apnea in patients are, for example, adenoidal hypertrophy. And adenoidectomy is something that we're clearly familiar with as ear, nose, and throat surgeons, as well as tonsillectomy. And we must identify and correct these pathologies in these patients because these surgeries may have significant benefits in patients. We must also be certain to identify patients who may have chronic rhinosinusitis with polyps or septal deviation, and institute relative management options for these diseases, including endoscopic sinus surgery, septoplasty if necessary, and of course, which we will talk about in a second, UPP excisional procedures for oropharyngeal obstruction. But it's very important to correctly identify the level of airway obstruction. We mustn't do blanket procedures. In other words, just blindly perform a procedure for obstructive sleep apnea based not taking into consideration the level of obstruction. This is likely the procedure will fail if that is done. So uvulopalatopharyngoplasty is an excisional type of procedure that was first described in 1981 by Fujita et al. It usually involves removal of the tonsils as well. The uvula and palatin is an excisional procedure in terms of removal of the posterior portion of the soft palate and uvula, tonsillectomy. And this was thought or is thought to widen the posterior airway. This procedure has actually been quite extensively studied, and one of the issues that I highlighted earlier is in terms of the fact that a lot of patients with OSA have multi-level obstruction. And in non-selected patients, the success rate of UPP can be quite low. Sure, et al. Did a study in 1996 that indicated that the success of UPP predominantly related to the level of obstruction. And when performed in non-selected patients, the efficacy was at best 50%. So once again, we have to take into consideration the level of obstruction. This is a palatal advancement flap, which essentially involves making a cut in the palate mucosa and suturing forward the soft palate, which essentially pulls the uvula forward and will likely widen the posterior oropharyngeal airway. This may be indicated in patients who may have oropharyngeal airway collapse. Lateral expansion sphincteroplasty. So reconstructive procedures have largely supplanted excisional procedures in palatal surgery. As I mentioned before, excisional procedures have been thought to be less effective when the obstruction site hasn't been properly identified. And this is a diaphragmatic representation of a lateral expansion sphincteroplasty, whereby the palatal-pharyngeus, the inferior aspect of it, is excised and actually tunneled into the soft palate mucosa with figure of 8 sutures used to secure the palatal-pharyngeus muscle to the soft palate mucosa. And in so doing, this actually brings the palatal arch forward and is thought to widen the oropharyngeal inlet, oropharyngeal airway, sorry. Pang et al. Performed a systematic review and meta-analysis showing a mean reduction of apnea hypopneic index of 86.3% in this versus the control group who did not perform surgery. This is another example of a surgical procedure performed, transpalatal advancement pharyngoplasty, which also attempts to widen the oropharyngeal inlet. It's commonly used in patients with persistent retropalatal obstruction post UPP, with drill holes placed from the oral cavity to the nose, osteotomies, anterior to a segment of bone that we're going to remove. Osteotomies are then performed through the hard palate to remove a section of bone, and the soft palate is then sutured through the osteotomies made in the segment anterior to the bone removed, and this pulls the palate forward, and again helps to increase the oropharyngeal airway. This was studied in 2017 by Volner et al., and it was thought to show a mean reduction in AHI of 68.3%. One point I want to make here is that these surgical procedures are done in support of continuous positive air pressure, and generally after continuous positive air pressure is actually tried, because continuous positive air pressure is the gold standard for the management of these patients. And of course, tongue-based procedures. There are multiple different types of tongue-based procedures, including radio frequency ablation. Usually, these are done in the lingual tonsil, partial midline glossectomy, as well as linguoplasty. And these can be aided with either the use of the robot or the laser. Usually done again in patients who may have failed uvulopalatal pharyngoplasty. There was a recent review done by Kazir and al. Showing success rates between 20 to 83% of these tongue-based procedures, but especially for radiofrequency ablation with multiple sessions. And of course, the issue with these tongue-based procedures, in addition to patients having post-op airway edema, is a significant pain that these patients may suffer as a result of the procedure. So this must be taken into consideration, and the cost associated with performing multiple procedures. So in addition, there are different hypopharyngeal procedures, so the different levels at which we perform surgery. Hypopharyngeal procedures are meant to widen the hypopharyngeal airway. So this is a diaphragmatic representation of genioglottal advancement, where an osteotomy is made in the symphysiomandible to advance the geniotubercle, which of course is the insertion of the genioglossus muscle. And in so doing, this actually pulls this fan-shaped muscle forward and advances the tongue. Other examples of procedures that can be used are the hyoid thyroid plexy, which is pictured here, where there's anterior and inferior fixation of the mandible of the, sorry, that should be of the hyoid bone, my mistake. And of course, as most of the extrinsic muscles of the tongue are actually, quite a few of them are attached to the hyoid bone, this anterior inferior movement actually pulls or increases the size of the hypopharyngeal airway. The ear advanced tongue suspension technique involves the use of a lingual frenulotomy with the placement of a titanium screw in the mandible and advancement of a suture around the extrinsic muscles of the tongue with placement of the suture in the titanium screw. And this is thought to pull forward the tongue anteriorly, and it's another method of increasing the size of the hypopharyngeal airway. Finally, mandibular maxillary advancement is commonly performed after the use of these phase 1 procedures or hypopharyngeal procedures that I mentioned before. Is usually indicated when these are not successful, and it's aided by the use of cone beam CT and volumetric analysis. The mandible and maxilla are advanced by the means of the 4-1 osteotomies through the alveolar process of the maxilla, as well as coronal osteotomies through the body and the mandible. And these are then advanced, as you can see in this diagram here. So this is more commonly indicated in concentric circumferential collapse of the velum, which is a contraindication to hypoglossal nerve stimulation, as well as in patients who may have skeletal abnormalities, such as the ones I mentioned, especially in patients who may have Crouzon syndrome, for example, or who have had failure of other surgical interventions. There are, however, several complications associated with this type of procedure. Airway edema is a clear present complication that can happen in these patients, as well as the malocclusion that is associated with removing a segment of bone and advancing the mandible and maxilla, relapse, nerve paresthesia, and as well as patients having temporomandibular joint issues post the advancement, as well as other surgical complications like infection and bleeding and the need for some subsequent dental work. a systematic review and meta-analysis was done evaluating the efficacy of mandibular maxillary advancement versus multi-level surgery for OSA treatment. Um, it's thought to have a relatively high success rate, even higher than that of other types of multi-level surgery, but the complication rate is higher. So our indications for this procedure really must be carefully considered. And of course, we're all familiar with tracheostomy. Tracheostomy bypasses the upper airway almost entirely. So it's usually curative for obstructive sleep apnea, but the morbidity associated with tracheostomy is quite high. There is significant psychosocial issues and inconvenience associated with the tracheostomy, especially in patients with no other comorbidities, and is usually used as a last resort after all other treatments have failed. Can be indicated, however, in patients who may have failed or who may have a neurodevelopmental impairment and patients who have severe OSA requiring urgent intervention. And it may be an intern options very selectively in some morbidly obese patients. All right, so some of the conclusions with respect to this presentation, take-home points. So it's important to understand that even though we as ENT surgeons surgically manage this disease, we are important in diagnosis and surgical management of this disease, that it must be implemented with a multidisciplinary team approach. We have other colleagues that assist with our diagnosis. Sleep studies are commonly implemented by the pulmonology team, as well as the patient may also benefit from dental evaluation, as well as evaluation by our general surgery colleagues for bariatric surgery. So we must really take this into consideration. We must also take into consideration the need for dietitian involvement as well when we're dealing with these patients. There's no one-size-fits-all procedure, and each patient is different. Even patients with similar anatomy are different and may require different procedures. Procedures may also be used in combination. It's an exciting area in sleep surgery because of the evolution of a lot of new procedures, but we still need to remember that our clinical evaluation is important. Our initial evaluation can often give us clues as to the level and the degree of severity of the patient's obstructive sleep apnea. And don't forget our mainstays and the fact that we need to give all of our patients a trial of positive air pressure once diagnosed when possible. Thank you. These are my references, and I open the floor to any questions.
Good. Just one or two comments. My understanding is that if you do lateral surgery, you may compromise someone using nasal CPAP subsequently because you get incompetence of the soft palate. And the other issue, of course, is that your perioperative management of patients with obstructive sleep apnea, we always insist that it goes to a high care unit post-operatively to be observed. So, you want to comment on that?
Sorry?
You want to comment on those two issues?
The second issue I'll comment on first because I didn't hear the first one. In terms of a high care bed, so it will be very beneficial to these patients because of the likelihood of post-operative edema. So the patients need to be in a monitored setting, especially when you perform multi-level surgery, as the risk of post-operative edema and airway compromise is significantly increased. So that may be why we put them in a high care, intensive care setting.
The first question was, if you do nasal surgery, you might compromise someone using nasal CPAP subsequently.
Sorry, Prof. I didn't hear. You said nasal surgery may compromise the ability of someone to use CPAP?
Yeah. If you operate on the soft palate, such as doing a UPPP, that could compromise using nasal CPAP subsequently.
Right, because of I'm thinking that would have to do with the excision one of the uvula and your ability to. I'm thinking that.
When you use nasal CPAP, then the soft palate flaps forwards, and it seals off the oral cavity from the oropharynx. And
Right, okay.
if you trim the soft palate, then you might have to rely on on a full face CPAP as opposed to nasal CPAP.
Okay.
Okay. Ian, what is your approach in Belgium?
Yeah, so we have a multidisciplinary team where we discuss our cases.
Yes.
That's most important.
Yeah. Okay. And you think septoplasty and nasal surgery has much role in obstructive sleep apnea?
It won't change much in the index, but it might help to improve tolerability of the CPAP.
Okay.
So that's why we do it. We don't do it to resolve the process completely.
I always think if you have a nasal septal deviation, you've got less space on one side but more on the other.
Yeah.
So if you look at the total airway, it's probably not much different. Am I right?
I think so.
Yeah. Any other comments? You just done your exam. Any comments on your side?
See a comment from the floor.
Yeah, ask for them. Good, unmute.
Yes. You can go ahead and ask your question.
Hello, can you hear me?
Yes.
Can you hear me? Okay. So you just think that there might be a possibility to do anterior palatoplasty, or you say, if I'm not mistaken, like the advancement flaps in the palate, especially in the soft palate. So whenever you do these surgeries, do you see any incident? How do you see the incidence of nasopharyngeal incompetence or velopharyngeal insufficiency?
Quincy, do you want to respond to that?
I didn't hear the question fully.
Could you repeat
All
your
right.
question?
Yeah. Okay, Prof. Just continue. Yeah.
Will you repeat the question?
Okay, I can repeat. So you have said that there might be a possibility to do for patients with also there's a possibility to do also anterior palatoplasty, or you said advancement flaps in the soft palate. So how do you see the incidence of velopharyngeal insufficiency or the nasopharyngeal incompetence problem in these patients postoperatively?
Quincy, do you want to comment on that? So you're asking that when you do soft palate surgery, how often do you see a nasopharyngeal incompetence?
Exactly. Yeah, that's my question.
So it would be much higher in patients who've had excisional procedures, who, for example, UPPP, and that's why you have the reconstructive procedures, such as expansion and palatal pharyngoplasties. I'm not sure the exact figures of incidence of velopharyngeal insufficiency in these specific patients. I don't have those figures with me.
Okay, because if we retract it anteriorly, yeah, there might be a decrement in the isthmus and narrowing of the nasopharynx. So that was the idea which was actually running through my mind. That was the reason that I asked you.
Yeah.
Okay.
Yeah. I've also seen a few patients over the years where the surgeon has done an adenoidectomy as well as a UPPP at the same time, and these patients have developed complete stenosis because you have a circumferential ring of denuded tissue. So the advice is don't do the adenoidectomy and the palate surgery at the same sitting. If you're going to do it in a stepwise or way to avoid that circumferential stricture. But to treat that stricture is almost impossible.
Oh. Okay, so we shouldn't be more aggressive.
Yeah, so don't be aggressive, don't do the adenoids and the palate at the same sitting.
Okay. Thank you so much, Prof. Sorry for not introducing myself. Actually, I am Dr. Obstructive from Ethiopia, St. Paul Hospital.
It's wonderful to have you join us. Thank you very much.
Thank you so much. Have a good time.
Any more questions?
Any other comments, questions from the floor?
Because thank you very much, Quincy. That was really an excellent presentation. I hope you're going to record that and put that on the website for us.
Okay, no problem.
Thank you.
Okay.
That's great.
Thanks, everybody. That concludes this meeting.